All right, so this will be a quick little video looking at application of RPW. We'll talk a little bit about the comparison between focused shock wave and radial pressure wave. So this is a radial pressure wave device, and then we'll get into really sort of how this is going to be applied in terms of a specific protocol. So the first thing we'll do is we'll go over some of the information, just a little bit of background to have a better understanding of what it does for us, and then we'll get into some of the application stuff. So acoustic wave therapy includes radial pressure wave, pulse wave, a few different names for it, and shock wave or extracorporeal shock wave therapy. It stems from lithotripsy. So lithotripsy is an acoustic energy that's designed to travel through the tissue, and the way that it's designed in its electromagnetic coil, it's a parabolic design, so it emits energy from different areas at lower concentration, but they converge to hit a target at a depth below the skin surface. So that's why you don't feel it at the skin surface, but it combines itself at the target tissue. In the case of lithotripsy, it's targeted at a stone. So lithotripsy uses a very similar process, or I should say that we are using in physical medicine a very similar process to target a tissue below the surface of the skin. Now, there are great differences in the energy. So lithotripsy is designed to be destructive. It creates disintegration of the stones by using energies greater than 4 millijoules per millimeter squared, versus what we're using in our market for therapeutics. We're not destroying anything. And in fact, we talk a lot about breaking up scar tissue, and really what it's doing is it's just creating a different biological environment in that tissue. So the energies that we're using are more like 0.5 millijoules per millimeter squared. So it's not intended to be destructive. And we can look at the history of soft tissue. It goes all the way back into classical Chinese medicine with gua sha, and using instruments to mobilize soft tissue to influence the blood flow and increase microcirculation to the surface, which reflexively was thought to increase circulation to the deeper tissue. We used implements, saves our hands. That way we can also use larger, broad contacts and treat different parts of the body. And that kind of, translated into what we know today is modern application with soft tissue mobilization. And we can again kind of thank James Syriacs for a lot of that approach that we utilize today with both our hands as well as utilizing tools. So very similar indications and process. However, we can get a lot deeper with today's technology than we can with tools superficially, because we're limited in not being able to transmit that energy through any great depth. So again, the earlier thought process was we were being destructive, but we're not being destructive. We're creating a difference in the biological environment. So even though, it feels uncomfortable, which is very typical of soft tissue mobilization, and certainly radial pressure wave and focused shock wave, but we are not being destructive. We'll talk a little bit about some of the cell differentiation processes that are going on that's actually causing some of these changes. Because it starts as acoustic, so it's a sound wave, and then when it hits the tissue, it becomes mechanical through mechanical transduction. Think about putting your face in front of a speaker, a loudspeaker, and sort of feeling that wind, which is actually the acoustic energy. It hits your face, and now it becomes mechanical energy as it transverses, any deeper into the tissue. So therapeutic ultrasound, the energy that it produces is much lower than what we're using with acoustic wave therapy. So you can't use your therapeutic ultrasound to do the same thing. And in fact, the oscillatory wave pattern is very different than the application of the wave pattern that we're delivering with radial pressure wave and focused shock wave. Very, very high, intense amount of energy over a very short period of time. And so what happens is with focus shock wave, we're using an electromagnetic coil to generate that through a membrane. Water is sort of the medium at which it transmits through, creates that acoustic wave, and goes through some ultrasound gel into the tissue. With radial pressure wave, and in this case we're using a pneumatic device, that there's a compressor inside of the device that emits air pressure through a tube to the applicator. And then inside the applicator is a tube that kind of looks like a barrel. And then there's a projectile inside of there. A barrel meaning like a gun barrel. That projectile slams up against the transmitter head and produces an acoustic wave. And then we transmit that acoustic wave through ultrasound. Because it is acoustic, we do use a medium to transmit that energy into the patient. And we do that repeated times over. So the wave will repeat and propagate, and that's actually what enhances the amount of energy that's delivered to the tissue, as well as that wave propagation that gives us the ability to get to a depth of upwards of 6 centimeters with radial pressure wave, and with focus shock wave, we can actually get as deep a therapeutic value of about 13 centimeters. So really some capability of delivering high amounts of energy, mechanical energy, into tissues that otherwise we can't do with other physical agents. So this is looking at the delivery of impact and the wave propagation as a result of that, and how it actually meets up with resistance against a tissue. So what we're showing is, as it's transmitting through the skin, adipose tissue to the muscle tissue, and essentially hitting bone. So if you look at figure D, as in dog, you can see where the energy accumulates as it hits a tissue that's very, very dense. And actually we see a slight change in the thermographic imaging, which actually technically it's a pressure image. And so we're seeing that accumulation of pressure right in that red spot, right above the D. And so that's as a result of the wave propagation. And this is just another pictorial looking at, why we set different frequencies to make sure that we get through the tissue that we're looking for. So here's the phrase that we're using. It's called tissue matrix disruption. It's an insult to the tissue that causes this change in the biological environment. And essentially what happens is it instigates this environment to really remind itself, for lack of a more scientific approach or description, is to remind itself for really what it is. So for example, in a calcific tendonitis, we emit the energy into the area, and that biological process instigates many of the things that we see in some of these other physical agents, increase in blood flow, microcirculation, nitric oxide. And then we actually start to see some other really cool things like cell differentiation, stem cells, mesenchymal, adipose cell tissue, which is an instigator to tissue regeneration, transcription, translation. And then another unique aspect of this is actually apoptosis, or getting tissue that doesn't normally belong in that area to essentially be resorbed. And that's why if we aim this at a tissue such as a calcific tendon, when we image, we see it, we treat, then we re-image, and it's gone. It's not because we blasted it away. It's actually because we created this environment as such that it was resorbed and then reestablishing of new tissue. So it's really, something unique and has shined really well in these recalcitrant areas. So basic chemical effects, cell wall permeability, stimulation, microcirculation, release of substance P. So that's especially with radial pressure wave. It's kind of interesting because we're also, getting a decrease in nociception because of, superficial stimulating free nerve endings, because at radial pressure wave, the amount of energy is greatest at the device itself, the applicator, and then dissipates as it goes into the tissue. Unlike focus shock wave, the greatest amount of energy is actually subcutaneous, and it's at the target. And then some other interesting, angiogenesis, osteogenesis, vascular endothelial growth factor. So really a lot of things that we would like in a tissue regenerative, process. And this is just a schematic. We're applying the physical energy. It's creating a biological response. And what's interesting is, and I equate it a lot to exercise, to where exercise provides a stimulus. It disrupts homeostasis, but there's an adaptation, and right. So it's very similar here that there's an adaptation to the energy, and the adaptation is not immediate. In fact, it may take several days later, to see some of these biological changes. We do see some acute things. We do see some increase in microcirculation. So we do see some redness in the area. Oftentimes we get an instantaneous decrease in pain, which may translate into a rather instantaneous improvement in performance, which again is a really nice thing because of the turnaround time that it takes to see patients to get a positive outcome. And then, so radio pressure wave and focused shock wave, they're both FDA approved, and that's device by device. And so be careful. There are devices out in the market that are not FDA approved, and ours recommend if you're wondering whether or not you can get away with something. I don't mean get away because you're doing something wrong, but actually, trying to purchase something that may be a medical class device that's not FDA approved, then it may increase your risk of potential fault if there was litigation and something were to happen. But in any event, devices on the market that are FDA approved, in particular the one that we're looking at here today, is temporary increased microcirculation, muscle pain, and active connective tissue to activate connective tissue. So we can really kind of make an argument for where that fits in a lot of what we do. So in comparison, these two technologies, so you can see that radio pressure wave on the left-hand side, the energy concentration is going to be lower than what we see with focused shock wave. Still very, very powerful, and if you could overlap these, you would see that the overlap of these two would be similar as if you overlap a pattern to a massager. So this is not a massage device. A massage device doesn't create that type of energy over such a short period of time. So for example, this device will actually emit 16 pulses per second at that energy density, which is much greater than any of those rotary type devices that we see with massage. Not that massage devices are a bad thing. They're different. They don't have the same depth of penetration or the same biological influence. Because they are both sound waves, and then eventually they become mechanical waves as it moves into the tissue. And because they're both acoustic waves, so we do want to use a medium to transmit that energy. Now, I'll show you here in a second. I also use topical agents, analgesics, for example, because it is an acoustic wave pattern, and if you have something that has really good transdermal capabilities to it, it really just enhances, the patient's experience and may have a further improvement in a decrease in pain and really lengthen the duration at which they're going to experience that decrease in pain. So indications, very similar for both of these, but first we'll look at contraindications. It's not that you can't treat a pregnant patient, you just don't treat over, the fetus area, so the abdominal pelvic region of a pregnant woman. You can treat the shoulder of a pregnant woman. So really when we're looking at contraindications of certain conditions, it's based on the proximity. So because these are fairly focal, like a lot of the other types of physical agents that we tend to use. Thrombosis, blood clotting disorders, cancer, some of these are just, well, the plausibility. So because it is a high amount of energy, you could create an inflammatory response. That's a side effect. That's not actually the benefit. And that's why we see some of these contraindications that are listed that you can, read here for yourself. Restrictions, or at least, precautions, is, making sure that we take into consideration the patient response. When you do this over bone, there's often a retraction reflex. Patient will try and pull away from you. Over large vessels, especially over nerves, patients may complain about the discomfort level. And again, just moving it around, you'll get a sense of what's acceptable to the patient and what's not acceptable. Side effects: swelling, redness, hematoma, pain during and after the treatment. Pain is different than discomfort. We'll talk about the protocol, but we actually are looking for discomfort because that's where it's shown to have a great deal of benefit. The cool thing is we're seeing in today's literature that lower intensities are providing us some similar outcomes and benefits, which decreases our chances of these things. Because when you're creating these side effects and you create inflammation, inflammation is a negative component to the healing constraints. It's not a necessary component that we maybe thought originally, and that we really beat people up in the earlier days of these devices. And frankly, it's not necessary. Classic indications. Let me backtrack. We are seeing benefits in acute situations. Again, lower intensities. It's a little bit beyond our discussion today, but there's some unique opportunities that we're seeing, especially with focused shockwave and a lot of anti-inflammatory effects, and even looking at the cellular effects. So it's pretty well established that we are getting anti-inflammatory effects at these lower energy densities, which again is kind of cool because that increases the continuum at which we can use a physical agent, which benefits us all, when we don't have to keep switching back and forth. So basically the itises, the apathies, chronic neuromusculoskeletal conditions is really where this thing has shined in the past. And so you can kind of imagine, where that is. So the application is typically ranges between 1,500 and 4,000 impulses. If you look at the literature, each session may last 10 to 15 minutes. That's, including all the setup and if you're doing a dynamic technique, but essentially most of it's going to be in a stationary position. So we are going to determine the area of concern, and usually it's the area of pain. So you ask the patient, where the problem is, and they take their finger and they point at it. You put your gel over that area and you put your applicator over the gel and you have at it. And you're going to move forward with changing some of the parameter settings that we'll look at here in a moment. Explain to the patient that, they are going to feel something. If it's radio pressure wave, the superficial area, some noise is going to occur. And please do read your user manual so you understand, how to operate and some of the limitations. It's loud, and so there is a recommendation of wearing, hearing protection if you are a clinician in the proximity and as well as the patient. And I will say, if you're treating in the region of the cervical spine, that's certainly is going to be a really, really good idea. Explain to the patient, we are looking for a level of discomfort. And that level of discomfort is usually about a 6 out of 10 on the pain scale. I don't like to use pain. I let them know that it's going to be a little bit uncomfortable, and we associate with that. And I did mention earlier, I like to use some topical analgesics, and by the time that actually sets in, I've already set my parameters, and so I'm not inhibiting that, versus when we look at some of the earlier literature and using anesthetics, lidocaine injections prior to treatment, we actually had the opposite effect because the patients weren't able to explain to us that we were overdoing it. We were being too uncomfortable and actually creating an inflammatory response, which could be detrimental. How do we know how much energy? Well, again, really our best indicator is going to be patient response, but take into consideration the area that you're treating, the depth of penetration, if you have to go through a lot of muscle tissue, adipose tissue, if you're closer to bone, more dense tissue has a higher elastic modulus, and so we will see that. So if you ever go over bone, you will know that it reverbs rather quickly, and so patients will experience that. And always, again, does it have to hurt? Again, kind of like exercise. Exercise doesn't have to hurt, but you know what? If you're working at any sort of intensity level, it's usually not the most comfortable thing because it's above homeostasis, and for some people that's uncomfortable. So I explain, use the exercise analogy that it is going to be a little bit uncomfortable, and we are beating up the tissue a little bit, because the idea, especially in these chronic conditions, recalcitrant conditions, we are creating disruption to the tissue matrix, okay? So in summary, where are we seeing this? Again, it really has shined in chronic conditions, which is fantastic. But again, we're seeing this in some acute conditions, which makes sense because it has been used to treat fractures, non-union fractures, seeing some really, really interesting work coming out from a prophylactic standpoint, you know, maybe treating muscle tissue prior to an intense bout of exercise, physical activity, an event, or, you know, follow-up treatment after they've performed an intense bout of physical activity, post-game, enhanced recovery, and that sort of thing. So beyond where it's really shined and done some really cool work is fantastic. So I posted, you know, a couple clips from our clinical guide here, just to kind of show you, okay, so here's an example of plantar fasciitis with associated heel spur. So we talk a little bit about, you know, what it is, and so plantar fasciitis is an irritation to the plantar fascia, which could result in bone spurring just because of chronic inflammation to the area. So oftentimes that painful area, that painful point, is where the plantar fascia attaches to the calcaneus. And so we would find the area of the calcaneus with discomfort, and we place the applicator over, like I said, the medium that we put in that area. Now, it's essentially going to be a stationary, and I'll show you in a moment that you can actually move it around a little bit. But think about dosage, and if you move it around too much, it changes the dosage. And we'll get into a little bit of dynamic technique here in a second. But we do have some guidelines. And again, they're very broad, and the reason is that it's got to be based also on patient experience and what they're feeling. So we're shooting for, again, that 6 out of 10 level of discomfort, and that tends to work pretty good. Frequency settings in general, we're usually somewhere between 8 and 15 or 16 hertz. And there are different applicator tips. I'll show you that here in a moment as well. Again, keep in mind that it's emitting the energy, so there's not a lot of fancy work that needs to be done here, not a lot of pressure, and really just following the anatomy. So there's not as much technique associated with this as there might be with some other manual therapy approaches. So here's an example of sort of the extension. Okay, so someone with plantar fasciitis, oftentimes we may find some Achilles tendon, you know, calcaneal tendon issues, and so I may want to go and then follow up my plantar fasciitis treatment point with Achilles tendon. I may actually want to do some dynamics along the plantar fascia, which you may be doing with some of your other manual therapy techniques. Well, now you can use this and certainly use your tools, but you know, like I said, this provides all the force that's going to be necessary without a lot of, you know, excessive energy from the clinician, and not a lot of, you know, extra motion or technique associated with that. And then some of these patients also have a tendency to have, you know, trigger points in the gastrocsoleus complex, and so, you know, you may decide to use this to treat those areas. Again, you could, you know, still use your dry needling, your ultrasound, your laser, your shortwave diathermy, whatever else it is that you're doing to manage those that, you know, you may already be successful, but this is just another opportunity to use, you know, the same device in your hands to accomplish that. So we're going to go to, I'm going to show you the device, so we'll go back to the live video feed here. So this is the device here. So the dial up top here is the bar setting. The bar setting is pressure setting. I'm going to turn it up. Right, so you can hear the pneumatic pump in there building pressure. So bar is just a conversion of PSI. So 1 bar is just shy of 15 PSI. So bars is going to be the amount of pressure that's going to be delivered. Then we have a counter. So as I indicated earlier, we've got between 1,500 and 4,000. I usually start personally, you know, 500 impulses per area. And again, we're still being therapeutic. I like to be conservative initially so I can see the patient response, because I really do not want to create too much side effect in them, because side effects actually limit, you know, the progression moving forward. A lot of people say, well, I, you know, do much better when I beat them up. Again, you're changing the tissue profile, so no doubt if you're doing that, you may eventually lead into, you know, tissue restoration, but we know that we don't have to go through an inflammatory cycle to then get to the fibroblastic stage, which is fantastic, especially if they're already inflamed. So the counter actually stops automatically at 2,000. I can just click the button and I can start again, or I can reset the counter. So that way it kind of keeps you on task to 2,000 is often going to be the average. And then we have the frequency setting. Okay. Normally, the first time I'm treating a patient, I'm going to start off in the low region. Often it's going to be at 1 bar and it's going to be at 4 hertz. Okay. So this is the applicator here. Inside is a barrel that has a projectile. You can hear that. So there's a little button right here that I'm pressing that that instigates the device applicator. Tube going through here, it increases the air going through, hits the projectile. So here we've got applicator tips. So there are a series of different applicator tips that actually mimic some of the tools we use in soft tissue mobilization. These are the straight ones that we use for basically emitting the shock wave, the acoustic wave pattern. So here's the red, it's the R40, and we have different convex, concave, different materials. That way we can actually control sort of the concentration, the depth of penetration. Here's the D20S, the D20 standard. So it's a broader head and has a greater depth of penetration to it. There's, this is also made in titanium, which has even greater depth of penetration, more concentration of energy. So we consider whether our depth of penetration is what we're going to be doing with it. And that's how we kind of determine the heads. Now, the clinical guides for our device also has some recommendations for what applicator you would use, but that may depend on, you know, maybe some of the other ones that that you're getting. So I'm going to use the example of, say, lateral epicondylitis. Okay, so I'm going to decide, you know, the area that I'm going to be treating, and again, I simply ask the patient, you know, where's your boo-boo? Okay, so I'm going to use, you know, gel, or like I said, I use an analgesic and a topical agent, so this works really, really well as the medium. And again, depending on what you're doing, if you want to, you can also mix it with your ultrasound gel. It's the same gel that you're also using for your ultrasound devices. This is going to be a little tricky one-handed, but so I'm going over the boo-boo, I'm going to turn it on. Okay. What I want to do is I want to ramp it up over the course of somewhere between 1 and 250 impulses. You can go faster, you can go slower, but what I'm looking for is I want to increase my intensity. So I get the intensity into the patient that's going to give me a 6 out of 10 discomfort factor. Okay? And then I'm going to increase my frequency. To keep it simple, if I'm superficial, I'm usually around 8 hertz. If I'm deeper, I'm usually around 15 hertz, 12 to 15 hertz. Because again, it gives us wave propagation. I will say it actually becomes more comfortable as you increase the frequency, because accommodation will occur in the superficial area. I can feel that right over the bone, and that's at 2.2 bar. It's tolerable, and I would say I'm actually at about a 6 or so, maybe even a 7. And again, it really is going to be dependent over the patient as well as, you know, the area. Okay, so really it's a stationary technique, and I hold it there. Now, what you may see others do, and what you may also do, is just to kind of move it around. It may increase the comfort, increase your surface area, but also keep in mind you would also increase the number of impulses. So really just kind of moving it around about the size of a nickel or up to a quarter. But really you're not moving it around a whole lot, because that's the energy density that you're trying to accomplish. Okay, so let's say I stayed in that area for approximately 500 impulses. Depending on the size, I may go to another one at least within 1 to 2 centimeters. Very similar if you're using like a class 3B laser and a pinpoint technique, because the influence that it has on the tissue is it's not pinpoint. It has a circumferential effect to the tissue. So you don't have to hit every single spot, but I'll usually try and go between create a grid pattern between 1 and 2 centimeters, right, for that pinpoint technique over the tissue. So again, look at the literature, and they're doing stationary techniques usually between 1 and 3,000 impulses is pretty consistent. Like I said, I do between 500 at each point. So again, I'm hitting that 1,000 per area, per pathological site in the initial phases, but it allows me to determine how the patient's actually going to respond. Now, after I hit that area, so in lateral epicondylitis, I'll usually ask the patient if they have a referral pain pattern. If it goes more distal, I'll use that dynamic technique and I'll perform a dynamic technique. Again, add some gel, your medium, and you're just going to be using some stroking patterns. Now, if you move it too fast, it's going to influence your wave propagation. You're not going to get that deep. Very slow, right? Same thing. If it was going into the biceps or in the triceps region, I would use the stroking technique and spend about another 500 to 1,000 impulses in that area. That's secondary to the actual approach of using radio pressure wave or focused shock wave is over the area of the pathological site. These are secondary to the condition. And again, you may choose to use laser or something else. This works really well if a myofascial release is going to be indicated. Okay, we clean them up. I will often have them do some range of motion, just give me some indication as to how they feel immediately. To me, that's important. So that way we have some sense of, you know, they come in the next time and they're thinking, oh, you know, that didn't work, or, you know, whatever the case may be. Well, you're doing pretty good when you left here. So I always ask, you know, what did you do when you left here? You know, gives us some indication as to how long, you know, it was before they came back. So here's the cool thing too, is we're treating patients about 1 time a week, especially if you're in the aggressive, you know, the 6 out of 10 chronic recalcitrant conditions. So you're not doing it 3 times a week. So the frequency is awesome, because if you're in a setting where I'm treating a lot of patients, then, you know, adding this to a patient regimen, I only got to figure out a way to integrate it 1 time a week, which is fantastic. If you're in an outpatient setting and it's, you know, typically cash-based, then I'm not having to charge patients a lot of extra money. So the average amount of treatments, the range is between 3 and 6, which is fantastic. And a lot of times it ends up being between 3 and 4 treatments total. So about 3 to 4 weeks, 1 time a week, between 1 and 4,000 impulses, and we're there. Hope this was helpful. We'll be having more on radio pressure wave and focused shock wave. This was kind of a quick overview as to what we got.